Been with Aurum now 5 years, and I started off my career with Aurum Institute having just got into NGOs with a desire to really make a difference. And I thought that the best place to start making the difference in South Africa, and especially in health, was in a non-profit organization. Before that, I'd been in the United States and became incredibly frustrated of hearing about this massive epidemic of HIV in South Africa. And there I was, sitting in the United States and not really able to do much about it. So when I came back here, I completed my master's at Wits and then started working for the School of Public Health afterwards, and decided that academia wasn't hands-on enough, and that's when I transitioned into working for non-profit organizations. I've based a lot of our quality improvement work on Dr. Edward Deming and also on Dr. Joseph Duran. They're the two sort of icons that a lot of our theory is based on. Dr. Joseph Duran taught us that in total quality management, we need to be able to take three things into account, and those are quality control, quality planning, and quality improvement. The second aspect of Deming's theory is a theory of knowledge, and a theory of knowledge helps us to develop an understanding of our systems. So there's a premise that our systems are complex. Our systems are not simple. We don't just work in this linear environment where A plus B equals C. Our health systems are really very complex, and so we need to develop theories of how our systems function, how our systems operate, so that when we introduce change, we learn a little bit more about our systems. We gain a greater understanding of how they respond. And so we start to inform future behavior by coming to a greater understanding and a theory of knowledge around how our system works. So we go into Department of Health, work with their staff, look at their systems that they use in order to operate. We look at the skill set of their staff, so we'll do training. We also do mentoring, so side-by-side mentoring. And all of that's done under the umbrella of health system strengthening. What we would do is we'd always start off with data. So when we'd go into a facility, one of the things that we would ask a facility manager or a TB nurse or an HIV nurse, a NIMR trained nurse, is, where are your challenges? What are the problems that you're currently having? And then we would want them to back that up with data. So we would then turn to either the DHIS data, the District Health Information System, or tier.net data, or go to their source documents. So we'd actually go into their registers and say, let's try to validate what you think is the problem with the data. After we've then really realized that it is a problem and the data has validated that, we will then begin a process of understanding why that happens. Getting clinicians to understand their data, getting clinicians to be able to interpret their surroundings, to be able to see their work as a process and not just work. And therefore, if it is a process, I can change it. And that the way I implement my clinical skills actually does impact on not just the patient in front of me, but on my colleagues, on the system as a whole. For me, data is just an interpretation of what you're doing. So it's about trying to help a doctor and a nurse to be able to say, is what I've done today making a difference? Managers are not using the data effectively because they're not learning to tell the difference between random, when it's just normal breathing, and even though it was a little bit up or a little bit down, there's no need for a major intervention at that time. Or in fact, it's just about your system has reached a level where it's operating at a really bad rate, but that's the common rate. So it's about trying to help them to access the data in a way that it's a lot more meaningful, because we want to bring about special causes So when I do introduce change into your system, has that change brought about a special cause variation, or is it still just random? It becomes this new way of thinking. You can't look at the same way, the world the same way, if you truly internalize improvement science. And that's what we're hoping to accomplish with the healthcare workers. We want them to begin to see the world in a different way. It also helps them to breathe that sigh of relief that we're not blaming you. We are not here to say it's this lazy nurse who keeps taking, an hour-long tea break. It's her reason why she's the reason why there's such long queues outside. But as we teach people about the systems theory, about understanding, coming to a better understanding of their clinics and that change is possible, they become a little bit more excited. And as they see their data change, they want to do more. One of the things that we've done is in trying to create an environment where quality improvement becomes a management style is incorporating into our management training. So the management training that we do, managers are trained on improvement because it is actually a management style. It's about moving away from that old traditional blame of you're responsible for this to management looking at their role of how do I create a system, an environment where change is encouraged, where change becomes the standard order. So for instance, we've done a series of workshops and I've called them It's My Legacy. And in that I appeal to, because you know that at the end of the day, people, they've gone into health because they want to make a difference. And so we talk to them about understanding data helps you to understand where you are right now, helps you to adjust your behavior so that when you leave a legacy one day, it's a legacy that you too will be proud of.